Now we'll try to discuss the knee joint, a very important, again, a very important joint, the knee joint. The knee joint is the largest and the most complex synovial joint in the body. So this is the largest joint as well as the um, very complex synovial joint. So this joint is compound and complex synovial joint consisting of almost 2 to 3 types of joint. One is the condylar joint and the saddle joint. If you remember, this is the classification, and here is the synovial joints. Within the synovial joint, this is involving 2 to 3 types within its own type. One is the cellular or saddle type of joint, second is the bicondylar or condylar joint, and the third is the hinge joint. So all these are included within this joint. That's why it is very complex joint as well as a compound joint. So there are two important joints within this joint. One is the two condylar joints between the condyles of the femur. These are the two condyles of the femur articulating with the two condyles of the tibia. So this is also called as tibio or femorotibial joint, because there is articulation between the femur and the tibia, between the two condyles of the tibia and the femur. So it is called as the femorotibial joint. And there is also a joint between this as well as the patella in the front. So it is articulation between the patella and the femur. So it is called as the femoropatellar joint. This is the saddle joint which will be present here. That will be called as the femoropatellar joint between the patella and the femur. And there is bicondylar joint between the two condyles of the femur as well as the tibia. So these are the joints which are included within this. Coming to the articular surfaces, what are the articular surface? As we have already seen, it is the articulation between the two condyles of the medial lateral condyles of the femur with the medial lateral condyles of the tibia. So this is the articulation between the condyles of the tibia and the femur. Along with that, there is also a patella which also come in articulation, which comes in contact with this joint, and it is also an articular bone here. So patella, the articular surface of the patella, also articulate with these two bones. So there is no role of the fibula in this joint. So you should remember, fibula will not articulate within the knee joint. So it is just between the femur as well as the tibia as well as the patella. Okay, so these are the articular surfaces of the three bones: the medial lateral condyles of the femur, the medial lateral condyles of the tibia, as well as the articular surface of the patella. So these articular surfaces are covered by articular cartilage. So here, if you can see here, it is shown in bluish color. This is called as the articular cartilage, also called as the hyaline cartilage. So it has a peculiar arrangement of this articular cartilage. If you see on the condyles of the femur, so it will be much more thicker at the center compared to the periphery. So it is much more thicker in the center compared to the periphery. So as you go to the periphery, it decreases in size. Here also you can see. So it decreases in size when it goes to periphery. Just opposite is the articular cartilage on the tibia. If you see here, the tibia is flat, almost flat. The articular surface is totally flat. So this joint becomes very unstable joint, because here there is the condyles which are rounded, and the other articular surface should be concave, but it is not so. It is almost flat. So this becomes opportunity for the dislocations. So to increase this concavity, the articular cartilage at the center here will be thinner, and at the periphery it will be thicker. So there will be increase in some concavity within this the articular surface of the two condyles of the tibia. So the articular cartilage here, if you can see a small thin line, it will be thinner at the center and thicker at the periphery, just opposite to that of the condyles. In the condyle, it will be thicker at the center and thinner at the periphery. So this will increase the concavity. Along with that, the shallowness is also decreased by the presence of something called as the, again, fibrocartilage structure called as the menisci. So they, if you can see here again the picture, so these menisci, again, they increase the concavity of the tibia. So now this is much more better stabilized compared to a flat surface. So the menisci also increase the concavity of the tibia. One is the articular cartilage itself, then the presence of the menisci. If you see the tibia from above, this is how it looks like. These are the two menisci. This is the medial menisci, larger one, and the lateral menisci, small one. And in between, this area is called as the intercondylar area. This is the intercondylar area between the two condyles of the tibia. If you see from above, this is how it looks like. So there are some important structures which are attached from anterior to posterior. This is the anterior part and this is the posterior part of the tibia seen from above. So this is the tibial tuberosity which will be in the front, where the ligamentum patellae will be attached. So here, this is the space between the two condyles. This is called as the intercondylar area, and there are some structures which are attached from before backward. There are almost 6 structures which are arranged from before backwards. The first structure is the anterior horn of the medial meniscus. If you can see here, so this is the medial menisci, and here you can see the anterior horn that will be attached actually here to this part. So this is called as the here will be the first attachment will be the anterior horn of the medial meniscus. And the second structure which is behind that will be the attachment for the anterior cruciate ligament. We will talk about this cruciate ligaments, very important ligaments within the knee joint which help in the stability of the knee joint. These are called as the cruciate ligaments. So here will be the attachment of the second structure which will be attached behind this will be the anterior cruciate ligament. Behind that will be the attachment for the anterior horn of the lateral meniscus. This is the lateral meniscus here. So here will be the attachment of the anterior horn of the lateral meniscus. Just behind that will be the posterior horn of the lateral meniscus, and behind that is the posterior horn of the medial meniscus. This is the medial meniscus here. So this will be the posterior horn of the medial meniscus, and behind that is the posterior cruciate ligament. The most posterior structure which is attached in the intercondylar area will be the posterior cruciate ligament. So these are the 6 structures which are arranged from anterior to posterior side in the intercondylar area. Now coming to the knee joint. As I said, knee joint, because the surfaces, the articular surface of the condyle of the femur are much more rounded, and the condyles of the tibia are almost flat. So this joint becomes a very unstable joint. So to stabilize this joint, then there should be more ligaments. So there are almost 13 ligaments which help in the stability of the knee joint. So what are those? So first we'll just name them, later we'll discuss them in detail. The first one is the capsular ligament itself, then the ligamentum patellae. So here you can see here, this is the synovial membrane, around that will be the capsule, outside that will be the capsule around the whole of the knee joint, and here in the front you can see the patella ligament. So patella ligament is in the front. If you remember, the quadriceps femoris get inserted to the base of the patella. Base of the patella is above, and from the apex of the patella it continues down as patella ligament getting inserted to the tibial tuberosity. This is called as the ligamentum patellae. Then there is tibial collateral ligament, then fibula collateral ligament, coronary ligament, oblique popliteal ligament, arcuate popliteal ligament, anterior cruciate ligament, posterior cruciate ligament, transverse ligament, meniscofemoral ligament, medial meniscus, as well as the lateral meniscus. All this structure help in the stability of the knee joint. So there are 13 ligaments which help in mainly in the stability of the knee joint. Now we'll try to discuss each of them one by one. The first thing is the synovial membrane itself. So as I said, like all the synovial joints, this is also lined by the synovial membrane. Within the cavity of this knee joint, from outside we have the fibrous capsule, and inside of that will be, it will be inside surface of the fibrous capsule will be lined by the synovial membrane everywhere except at the articular surfaces. On the articular surface, this synovial, if you can see here, this is the synovial membrane. It covers the whole of the knee joint as well as the spaces, but it doesn't go over the articular surface because this articular surface will be lined by the articular cartilage. So it seizes at the periphery of the articular cartilage. And this synovial membrane will continue above into a bursa which will be connecting with the knee joint. This is called as the suprapatellar bursa. We will discuss about this bursa again in detail when we discuss the bursas itself. Coming to the tibial collateral, here you can see here, this is the fibrous capsule covering the whole of the knee joint. This is the fibrous capsule, and in the front we have the patellar ligament, and inside will be lined by the synovial membrane except at the articular cartilage. So here till here it will come, and above this here will be the articular cartilage itself. So it will not be on the articular cartilage. Coming to the next ligament, that is the tibial collateral ligament. In this picture, if you see here, it has not been shown actually, so that's why I have marked here. This is the tibial collateral ligament. So this is said to be morphologically, it represents the detached part of the tendon of the ischial part of the adductor magnus. If you remember, the adductor magnus has a very big insertion into the linea aspera of the linea aspera, and it continues all the way up to this tubercle here. This is called as the adductor tubercle. So this tendon begins from this adductor tubercle from the medial epicondyle and runs down to the medial condyle of the tibia as well as the shaft of the tibia. That's why it is said to be the degenerated tendon of this adductor magnus. So adductor magnus will come till here, adductor tubercle, and it will stop. And this tendon will begin from here and extend all the way up to the shaft of the tibia. So this is said to be a degenerated tendon of the adductor magnus muscle. It has two parts, superficial and deep parts. As I said, above it will be attached to the medial epicondyle of the femur, and below it will be attached to the shaft, medial condyle, as well as the shaft of the medial side of the tibia. Coming to the next ligament, that is the fibular collateral ligament. You can see on the other side, on the lateral side, this is the ligament. This is called as the fibular collateral. The tibial collateral ligament will be on the medial side, and the fibular collateral ligament will be on the lateral side where the fibula is present. So that's why it is called as the fibular collateral ligament. So here this ligament is also said to be a degenerated tendon of a muscle called as the peroneus longus. Peroneus longus is a muscle of the lateral compartment of the leg. There are two muscles, peroneus longus and the brevis, in the lateral compartment of leg. The peroneus longus is a bigger muscle which take origin from the upper part of the fibula. So above this, this tendon, if you can see here, this tendon is present. So this is said to be the degenerated part of the peroneus longus muscle. So this ligament will be running from the lateral epicondyle of the femur, and it will go all the way down to the head of the fibula, or to a process here. This is called the styloid process of the fibula. So it extends from the lateral epicondyle of the femur and it goes to the styloid process of the fibula. Then we have the one more ligament called the oblique popliteal ligament. If you remember, the semimembranosus will be getting inserted. Semimembranosus is a muscle of the posterior compartment of the leg, which is also of the thigh, which is also called as the hamstring compartment of the thigh. So this muscle will be getting inserted to a groove on the medial condyle of the posterior surface of the medial condyle of the tibia. There is a small groove here. This is called the groove for the semimembranosus. So this muscle semimembranosus will be getting inserted to this groove of the semimembranous area. Along with that, it gives some expansion. This is called the oblique popliteal ligament. So it is an expansion derived from the insertion of the semimembranosus. The oblique popliteal ligament will extend upwards and laterally. If you can see here, it will be extending upwards and laterally from the posterior surface of the medial condyle of the tibia to the lateral part of the intercondylar line of the femur. So it is almost on the attached to the fibrous capsule. Okay, so it blends with the posterior surface of the fibrous capsule, and this posterior surface of the fibrous capsule will form the floor for the popliteal fossa. So this will be this muscle, this tendon ligament will be oblique popliteal ligament will be also form the floor of the popliteal fossa, and because it in the floor of the popliteal fossa, so it is pierced by middle genicular vessels as well as nerves. Now coming to one more ligament of the knee joint, that is called as the arcuate popliteal ligament. This ligament is not shown here in this picture, but you can imagine it looks like similar to this ligament here. It is Y-shaped fibrous band which extends from the styloid process of the fibula. So fibula is on the other side, on the lateral side. This view is from the medial side. Okay, so here is the fibula. So from this styloid process of the fibula, there is a ligament which extends above. Its posterior band arches over the tendon of the popliteus and is attached to the lateral condyle of the tibia, and the anterior band is deficient, which passes deep to the fibula-collateral ligament, and it is attached to the lateral condyle of the femur. So this is how the arcuate popliteal ligament is present. Then there is also a very important ligament, as I said before. These are called as the cruciate ligaments. There are two cruciate ligaments, anterior and posterior cruciate ligament. If you see here in this picture, again this is the picture, coming back to this picture. So this is the anterior cruciate ligament and this is the posterior cruciate ligament. So these are the two cruciate ligaments which are very important in the stability of the knee joint. They are called as cruciate because they cross. If you see here, this is the anterior cruciate ligament crossing and going behind. The posterior cruciate ligament from behind it is coming forward, so they cross each other. So that's why it is called as crossing ligaments or cruciate ligaments. These ligaments, if you see, these are intracapsular but extrasynovial. So if you here will be the femur, and this whole joint will be covered by fibrous capsule from outside. But if you see, this is the this pinkish or browny structure which is shown here. This will be the synovial membrane. If you see the synovial membrane, it is covering the whole of the knee joint cavity, except it comes all the way in the front and it tries to keep these two ligaments outside. So even though they are intracapsular within the capsule, but they are extrasynovial. They are not within the synovial cavity, so they are extrasynovial. That is how they are placed. They are also they are named as anterior and posterior according to their attachment to the tibia. So even though the anterior cruciate ligament go behind and get inserted to the posterior part of the fibula, the femur, and the posterior cruciate ligament, even though it takes origin from the posterior part, we cannot say origin. We should say always say for the ligaments it will be attachments. Okay, so it will be attached on the posterior part of the intercondylar surface of the tibia, and it comes anteriorly and get again attached to the anterior part of the femur. So these are called as anterior and posterior depending on the attachment to the tibia. So this is attached anteriorly to the tibia, so it is called anterior. This is attached posterior to the tibia, so it is called as the posterior cruciate ligament. Both are very important ligament, as I said, because they become taut at extreme flexion and extension of the joint. So as I said, because this joint is a very unstable joint, because this tibia is almost flat, so the condyles can easily slip. So to prevent this slipping, especially in extreme movement, these two ligaments prevent extreme movements like extreme extension as well as the extreme flexion of the knee joint. These ligaments are actually developed from the posterior part of the primitive intercondylar septum. Coming to the anterior cruciate ligament, as you can see in this picture, if you remember, go back to this intercondylar surface. So here is the attachment of the anterior cruciate ligament on the tibia. So below, attached to the anterior part of the intercondylar area of the tibia, in between the anterior horns of the medial and lateral meniscus. If you can see here, these are the two horns of the medial as well as lateral meniscus, and between them will be the attachment of the anterior cruciate ligament. If you can see here in this picture again, so the two condyles are here, and in between is the anterior cruciate ligament. Then this cruciate ligament, as I said before, it will go back and get attached to the posterior part of the medial surface of the lateral condyle of the femur. If you can see here, this is the lateral condyle because it is near towards the femur, so that's how we can identify this is the lateral condyle, and this tendon is going toward the medial surface of this lateral condyle and getting attached to that part behind. What is the function of this anterior cruciate ligament? As I said, these cruciate ligaments are very important. So what is the function? So one is it binds the two bones together. So it will connect these two bones and they will keep the two bones together. The femur as well as the tibia are kept together by the presence of this cruciate ligament, especially the anterior cruciate ligament. Then it also prevents hyperextension, as I said, because it is attached in the front here, and then on the femur it is attached behind. So whenever it tries to extend, up to a certain extent you allow, but after that it becomes taut whenever you try to hyperextend. So it prevents hyperextension of the knee joint. It also prevents forward displacement of the tibial condyles, and the tibial condyles, if they want to on the stable femur, if the tibial condyles try to slip in the front, then it is prevented by this anterior cruciate ligament. In extension, it forms vertical axis around which the femur rotates in locking and unlocking. So whenever you know the locking during of the knee joint as well as unlocking, the femur as well as the tibia come in almost in the same angle. So whenever they come in the almost in the same angle, then this ligament will actually act as the axis for the two bones to rotate on that, so that there can be locking as well as unlocking. So for unlocking and locking, the axis is formed by this ligament. This is about the anterior cruciate ligament. So these are some of the functions of the anterior cruciate ligament. It binds the two bones together, it prevents hyperextension, it prevents forward displacement of the tibial condyles, as well as in case of extension, it forms the axis, vertical axis around which the femur rotates on the tibia. Coming to the posterior cruciate ligament, this is attached to the posterior part of the intercondylar area. If you can remember, so here is the attachment of the posterior cruciate ligament. So it is posteriorly attached, so it is called as the posterior cruciate ligament, but it comes forward and get attached again. If you can see here, come forward above and it get attached to the lateral surface of the medial condyle of the femur. So it will come in the front. If you can see here, it is coming in the front and get attached to the lateral surface of the medial condyle, because again the fibula is on the lateral side and the tibia is on the medial side, so this should be the medial condyle. So it is getting attached to the medial condyle on the lateral surface. What are the functions of the posterior cruciate ligament? This also helps in the binding of the two bones. As you can see, both the ligaments help in the binding of the two bones together, keeping the two bones together. This ligament, apart from that, also prevent backward displacement of the tibial condyle. If you can see here, so this ligament, anterior cruciate ligament, is preventing anterior displacement of the tibia over the stabilized femur, and the posterior cruciate ligament prevents actually the posterior dislocation or displacement of the tibia over the fixed femur. Both the cruciate ligaments prevent side to side displacement also. So these ligaments also prevent the side to side displacement of the tibia over the femur. So these are some of the functions of the anterior and posterior cruciate ligament. Coming to the menisci, these are semilunar cartilages you have already seen here. So these are the two cartilages, fibrocartilaginous structures which are present within the cavity of the this synovial joint, that is the knee joint. Menisci are fibrocartilaginous structures which project from the fibrous capsule as incomplete partition. If you can see here, they are not complete. They totally don't divide the whole of the cavity into two, but they are incompletely dividing this space, the cavity of the knee joint, into an upper half as well as a lower half. The upper part will be called as between the menisci and the fibula will be called as the meniscofemoral compartment, and below this there is a small space again below this menisci. This is called as the meniscotibial. Above will be the meniscofemoral and below will be the meniscotibial compartment. These menisci will divide the whole of the cavity into an upper part, meniscofemoral, and below part that will be called as the meniscotibial compartments. These menisci, as you already seen, there are two. One is medial and lateral menisci. So how do you identify? This is the medial menisci, which is much more larger compared to the lateral one, and this lateral one is much more rounded. So the medial menisci is semilunar in shape, almost half crescent moon shape, and longer anterior-posteriorly. If you can see here, if you measure this anterior-posteriorly, it will be much larger compared to the lateral menisci. So the lateral menisci is almost a circle. It is forming almost a circle. It almost forms 4/5 of a circle. Only a small part is remaining, which if it completes, then it becomes a complete circle. So this is almost a circle, almost forming 4/5 of a circle. Okay, so this is the lateral meniscus and this is the medial meniscus. What is the function of these menisci? Menisci is the puller of the meniscus. Okay, so they make articular surfaces more congruent. If you can see here, as I said, the tibia is a very flat bone on the articular surface, so it has to be congruent, so it has to be made somewhat concave, and that can be done by these menisci. So they increase the cavity of the tibial condyles for better adaptation, as well as they are made more congruent by these menisci. Then they also acts as the shock absorber, because they are present between the femur and the tibia. So whenever you jump from a height, these two bones are prevented from coming and touching each other by the presence of these menisci. So they act also as the shock absorber. They also maintain potential space for flushing synovial fluid to provide nutritional supply to the cartilages. If these two bones come very close to each other, there is no space, and the fluid, the synovial fluid cannot flow through this, and then there will be a deficiency of nutrition to the articular surface, especially the articular cartilage, as well as small part of these bones are also supplied by the synovial fluid. So this synovial fluid will be providing the nutrition to the surfaces, and this can be done by keeping a space between the articular surfaces. The peripheral margin of the menisci are vascular and inner part are avascular. The peripheral margins of these menisci are vascular because they are supplied by the same arteries which are supplying the capsule of the knee joint. And the medial part, they are avascular, so these medial parts will be supplied by the nutrition from the synovial fluid, and they have the capacity to regrow. And these menisci give an additional nerve supply. Their nerve supply gives an additional sensory function for better stability of the knee joint, because if there is even slight injury, as I said, if you jump from a height, so these menisci also have nerve supply. So if there is any trauma, these menisci will also send an additional sensory impulse, which will give a shooting pain, and immediately you take action. And so hence this menisci with additional nerve supply will give additional sensory function, which again it prevents even small changes within the knee joint. And if there is any change, even small changes, then immediately there will be sensation which will be felt with pain and other things, and then you try to take immediate action. So these are some of the important functions of the menisci. One is they make the articular surfaces more congruent, they increase the concavity of the tibial condyles, they act as this shock absorber, they maintain potential space between the surfaces, they are vascular in the center and avascular in the medial side, and that is supplied by the nutrition from the synovial fluid, as well as they give additional nerve supply to these knee joint, which will prevent even small changes and help in the stability of the knee joint. There are also some small ligaments called the meniscofemoral ligament, which will be attached to the posterior horn of the lateral meniscus. So here is the lateral meniscus, and to the posterior horn of the lateral meniscus is connected to medial condyle of the femur. So it is attached to the medial condyle of the femur by two ligaments, anterior and posterior. Anterior meniscofemoral ligament, which is called as the ligament of the Humphrey, and there is also posterior meniscofemoral ligament, which you are seeing from here. This is the lateral meniscus, and there is a ligament which is running from there to the medial condyle. This is called as the ligament of Risberg. So these are also some important ligaments which help in the stability of the knee joint. They regulate actually the forward movement of the lateral meniscus during extension. Whenever you extend, so this ligament will be actually pulling the lateral meniscus forwards. Apart from that, there are also some small ligaments called as the coronary ligament. Coronary ligament is actually a small ligament which connects the peripheral margins of the menisci to the which attach the peripheral margin of the menisci to the capsule. Part of the fibrous capsule which provides attachment to the peripheral margin of the median and lateral meniscus on either side. Okay, so this is the capsule and these are the menisci, and they are connected by this coronary ligament. The transverse ligament, here you can see here, this is the transverse ligament which connects the anterior horn of the medial meniscus. So this is the medial meniscus anterior horn with the anterior margin of the lateral meniscus. Here also you can see in this picture. So there is the transverse ligament of the knee joint. And this ligament is present in almost 40% of the subject, not in everybody, but almost 40% of the subject. You can see the transverse ligament. Now coming to the bursas around the knee joint. As I said, the knee joint is a very unstable joint, so it has lot of ligaments as well as lot of muscles which are acting. So this is also covered by a lot of bursas which prevent the friction between the bones and the tendons of the muscles. So there are around 13 bursae here. Bursae is the plural of the bursa. So there are 13 bursae, 4 in the anterior, 4 in the lateral, and 5 in the medial. So the most important, which are clinically again important, will be the anterior. So the first one is called as the suprapatellar bursa. There is a very important bursa above the patella. So this is called a suprapatellar because it is above the patella and behind this quadriceps femoris. So this is called the suprapatellar bursa, which communicates with the knee joint. So if there are any changes in the knee joint and if there is any inflammation of the knee joint, then this will also get inflamed, and you can see the pain and redness, everything above the patella. So this is because the suprapatellar bursa will be communicating with this. So if there is any swelling, pain, redness, everything, you can see, in case especially if there is osteoarthritis or rheumatoid arthritis, something like that, at that time you can see as well as feel the increase in temperature and the pain, severe pain and redness, everything above the patella, because this is because of the suprapatellar bursa, which communicates directly with the knee joint. The second bursa is subcutaneous prepatellar bursa. If you can see here, this is a prepatellar bursa. It is in the front of the patella, so it is called as prepatellar. Pre means front, supra means above, pre means in front, and infra means below the patella. So all are related to the patella, so they are named according to their position with the patella. The suprapatellar bursa, this is the prepatellar bursa, which is subcutaneous, just in front of the deep to the skin is this prepatellar bursa. This bursa is very important, especially in case of maids. Whenever the maids clean the floor they clean the floor. At that time they will be kneeling and actually putting their pressure on the knees, and they try to clean the floor. So this bursa are prone to get infected and inflamed. So that's especially in case of housemaids. So that's why it is called as the housemaid knee. Then there are some infrapatellar bursa. One is the subcutaneous bursa and the deep bursa. So this is the subcutaneous infrapatellar bursa. Again, these are also prone for infection and inflammation, especially in case of the clergies. In case of the churches, clergymen, they especially actually pray with kneeling down on their knees, and this will especially inflame the infrapatellar bursa. So that's why it is called as the clergyman's knee, where the subcutaneous infrapatellar bursa will be inflamed. Apart from that, there is also one bursa which is deep inside. This is called as the deep infrapatellar bursa. So if you can see here, deep inside here is the deep infrapatellar bursa, which is also present deep to that. So these are the four anterior bursas which are very important: suprapatellar bursa, subcutaneous prepatellar bursa, then we have the subcutaneous infrapatellar bursa, and the deep infrapatellar bursa. Apart from that, there are other bursas which are on the lateral and medial side. So on the lateral side, we have a bursa deep to the lateral head of the gastrocnemius. Then we have the bursa between the fibula collateral ligament and the biceps femoris. Then we have the bursa between the fibula collateral ligament as well as the tendon of the popliteus, bursa between the tendon of the poplite as well as the lateral condyle of the tibia. I don't have pictures for all these bursas. And on the medial side, we have also bursa, 5 bursas. Bursa deep to the medial head of the gastrocnemius. Here is the lateral head, and here the medial head. Under both these heads, we have the bursas. Then there is also a bursa called the anserine bursa. Then there is bursa deep to the tibial collateral ligament. Then there is a bursa just below the semimembranosus. Then bursa between tendon of the semimembranosus as well as the semitendinosus. So these are some of the bursas which are present around the knee joint, but the most important will be clinically will be the anterior bursas in case of the knee joint. Now coming to the anastomosis around the knee joint. This we have already discussed in the popliteal fossa, but still just to recall the things. So the knee joint is highly vascular joint supplied by lot of arteries which anastomosis around the knee joint. So what are the arteries? We have already discussed the 5 genicular arteries. One is the superior lateral genicular artery, then we have the inferior lateral genicular artery, then superior medial genicular artery, and the inferior medial genicular artery, and a central artery, which all these arteries will be supplying the knee joint. So these are the branches which are coming directly from the popliteal artery here. So this is the popliteal artery. If you can see here, this is the femoral artery coming from the femoral triangle into the adductor canal, and then it pierces the adductor magnus muscle. This is called as the adductor hiatus, through which this femoral artery from the adductor canal will be passing into the popliteal fossa. So this is the popliteal artery, and these are the 5 branches, genicular branches. Genu means knee, so genicular branches are those branches which are supplying the knee joint. Then apart from that, there is also the descending genicular branch of the femoral artery. If you can see here, this is the femoral artery. So before it passes through the hiatus and become the popliteal artery, it gives a branch. This is called as the descending genicular artery. Then we have the descending branch of the lateral circumflex artery. If you see here, this is the descending branch of the lateral circumflex artery. If you remember, lateral circumflex femoral artery is a branch from the deep artery of the thigh, or the profunda femoris artery. Then we have the two recurrent branches of the anterior tibial artery. If you see here, this popliteal artery will continue down as the posterior tibial artery, as well as it gives a branch. This is called as the anterior tibial artery. So anterior tibial artery will give a branch. This is called as the recurrent branch of the anterior tibial artery. Then the posterior tibial artery also gives a branch. This is called as the circumflex fibular artery. So these are some of the arteries which supply the knee joint. So this is a rich anastomosis of lot of arteries which communicates with each other, and then they supply the knee joint. Coming to the nerve supply, as I said, nerve supply of the knee joint is very important. Especially I had told you about the referred pain. Again, the referred pain is that pain where actually there is a problem in the hip joint, and it is sense as though it is from the knee joint, because the same nerves will be supplying the hip joint as well as the knee joint. So the brain cannot differentiate between pain from the hip joint and the knee joint, and it misinterprets in the other joint. So this is called as the referred pain. So the nerves which will be supplying both the hip joint and the knee joint will be two, that is the femoral nerve as well as the obturator nerve. So the knee joint is supplied by 10 nerves, 3 branches from the femoral nerve. If you remember the femoral nerve will be giving anterior and posterior division, and the posterior division will be supplying 3 vasti, and from the 3 vasti they will be supplying the knee joint. The vastus lateralis, vastus intermedius, vastus medialis, all will be supplied by the femoral branches, the posterior division of the femoral branches, which in turn supply the knee joint. The rectus femoris branch will be supplying the hip joint. So the same femoral nerve will be supplying both the hip joint as well as knee joint. So these 3 branches are from the 3 vasti muscles which are coming from the femoral nerve. Then 3 branches from the tibial nerve through the superior, inferior as well as the medial genicular nerves. Then 3 branches from the common peroneal nerve. Tibial nerve and common peroneal nerve are branches of the sciatic nerve, and they will be supplying the knee joint. And 1 branch from the obturator nerve. So actually the femoral nerve and the obturator nerve are because of these 2 nerves which supply both the hip joint and the knee joint, you can feel the referred pain. Okay, so these are some of the nerves, the 10 nerves which supply the knee joint. The 3 branches from the femoral nerve, 3 branches from the tibial nerve, 3 branches from the common peroneal nerve, and 1 branch from the obturator nerve. All these nerves will be supplying the knee joint. So it is richly vascular as well as richly supplied by the nerves. So hence the L3, L4, L5 and S1 will control the knee movements, and L3 and L4 regulate the extension, and L4 and L5 will regulate the flexion of this movement depending on the nerves as well as the muscles which they will be supplying. Coming to the movements at the knee joint, there are 2 important movements. One is the flexion and extension, and there is rotation movement. So rotation movement, which is the locking as well as the unlocking of the knee joint over the fixed tibia. So this is the rotation movement, where we can see the medial rotation of the femur on the knee, actually on the tibia. So this is called a locking, and the opposite movement will be the unlocking of the knee joint. Locking is defined as medial rotation of the femur, as you can see in the picture, medial rotation of the femur on the fixed tibia during terminal stages of extension at the last 30 degrees of extension. When you are extending, you are not only extending the knee joint, but also there is a rotation, medial rotation of the femur over the tibia. So this is called as the locking of the knee joint, which help actually for long standing of the person without spending any energy. So once you stand for a long time, then the knee joint will extend and locks, and then all the muscles will become relaxed, and you don't spend much energy if you stand for a standing for a long time. And when you are again flexing the knee joint, first it will unlock, then it will flex the knee joint. So these movements are done by some of the muscles. Especially the flexion is done by the muscles which are present in the posterior compartment of the thigh, which are called as the flexors of the knee or hamstring muscle, that is the biceps femoris, semitendinosus as well as the semimembranosus. Along with that, there are accessory muscles which help in the flexion, that is gracchalis, sartorius, popliteus and the gastrocnemius muscle. Coming to the extensions of the knee are present in the anterior compartment of the muscle, especially the quadriceps femoris, which help in the four muscles: rectus femoris, vastus lateralis, medialis, as well as the intermedius. These are the four muscles, quadriceps femoris together, they are called as quadriceps femoris. Those muscles will be helping in the extension of the knee joint. Along with that, there is also the tensor fascia lata, which is said to be the muscle of the anterior compartment as well as the gluteal region. So this tensor fascia lata also help in the is a accessory muscle which help in the extension. Coming to the medial rotation of the flex leg, it will be done by the popliteus muscle, semimembranosus, as well as the semitendinosus. Accessory muscles are sartorius and gracchalis. Coming to the lateral rotation of the flex leg, that will be done by the biceps femoris. Coming to the last aspect of this knee joint, the applied aspects related to the knee joint, clinically important features. One is the osteoarthritis. So knee is a very common site for the osteoarthritis, especially in case of old age. Because of the osteoporosis, there will be arthritis also in the knee joint, inflammation, as well as severe pain in the knee joint. This is mostly seen in the knee joint. The syphilitic arthritis is also common in case of the knee joint, and the tuberculosis, especially the pyogenic infections, are more common again for the knee joint. Injury to the menisci are present only in the knee joint, so the injuries to menisci should be in the knee joint itself, and these menisci injuries are also common in case of the knee joint. Injuries to the cruciate ligament, again the cruciate ligaments are present in the knee joint, and whenever there is a displacement of the tibia, I said the cruciate ligaments will be preventing displacement of the tibia over the stabilized femur, and if there are any traumas or something, road traffic accident, something like that, and if there are any dislocation, this is because of the injuries to the cruciate ligaments. Injuries to the collateral ligament, this is also seen when there are any trauma to the knee and displacement of the tibia and the fibula. Injuries to the collateral ligament. And bursitis, because there are a lot of bursas around, so they get inflamed, and I named some of them: the housemaid knee as well as the clergyman's knee. So these are the inflammation of the bursas, which is called as bursitis. Collection of the fluid in the knee joint is also common, because whenever there is bursitis, inflammation of the knee joint because of any reason, osteoarthritis, rheumatoid arthritis, or something else, then it all leads to collection of increased collection of fluid in the knee joint. Whenever there is inflammation, there will be collection of the fluid, increased production of the synovial fluid. Then there are two conditions called as the genu valgum as well as the genu varum. Genu means knee, so genu valgum as well as the genu varus. So if you see here, this is called as the genu varus. When the knees are bowed up and they are outside, they are diverted outside, then this is called as the knock knee. This is called as the bow knee. Okay, so whenever you see the knees are directed upwards, then it is called a bow. It looks like a bow. Just opposite is the genu valgum, where the two knees are directed towards each other, and they will be knocking each other. So this is called as the knock knee. They knock in the front as well as knock to each other. So they are called as the knock knee, and these are called as bow knee because they look like a bow and or arrow, so it looks like a bow. So that's what is called a genu varum is also called as the bow knee, and the genu valgum is also called as the knock knee. And fractures of patella are also common whenever there are any injuries to the knee joint. So these are some of the important applied aspects related to the knee joint.